Okay, so a very good evening, good morning, good afternoon to all the participants. So today we welcome Dr. Hemang Zala from Ahmedabad, India, with Dentistchannel Online, and today we'll be having a webinar on short dental implants. A very warm welcome, Dr. Hemang, for
Thank you so
coming
much.
on board with us and sharing the knowledge and the webinar on the short dental implants. So without wasting any time, I would start with a small introduction about Dr. Hemang. So Dr. Hemang Dr. Hemang Zala MDS has over 18 years experience in clinical dentistry. Dr. Zala did his graduation from Government Dental College in year 1999. He currently runs his own dental hospital clinic in Ahmedabad, Gujarat. His trademark is to thoroughly educate and comfort his patients. He is a patient-focused dentist seeking on performance and seeking to contribute skills and skills in the dynamic of dental office. He owns a career-long record of performing minor and major dental procedures and adapting to changes in technology and dental intervention techniques. Uh, Dr. Zala has maintained a client base of thousands, uploading a reputation as professional, empathetic, and personable practitioner. So again, I think we should start with the webinar. And to all the participants, if you have any questions, kindly put your questions in Q&A session. Do not put them in chat box, and your questions will be answered by the end of the webinar. So over to you, Dr. Hemang.
Thank you. Thank you so much for your introduction. So it's like I'm practicing in Ahmedabad and I'm not attached with any company or anything. This is just I like to share my knowledge with everybody. And with the short implants, I should say I have follow-up of more than 15 years now on the cases. So whatever cases I want to share you, I show you are cases which are being done by myself, and it's not somewhere I have picked from the website or somewhere. And I have made some classification just to make things more easier for you to understand or for clarification. Even that classification are not actually in some literature or anything. Right. So am I audible properly, Dr. Ishan?
Yes, Dr. Hemang, you're audible.
Right, right. So before wasting time, just we'll start with our presentation on short implants. The topic is actually really long, but I will try and make it as short as possible. And we are going to cover up points like what are the short implants, crown to implant ratio, biomechanics of short implants, how it works, importance of connection and prosthetic consideration, why are they necessary, and what are other alternatives to the short implants? Are they reliable? I will show you my clinical cases and then we will finally conclude. So what are the short implants? There were no such criteria of the size of the short implants. Before few years or many years, the people used to consider 12 mm, 14 mm as the shortest implant. Then with evolution, people came to know that, as they become more and more aware that even the 10 mm implant is working well, why we should consider as 12 or 14 mm as a short implant. So then they consider 10 mm as a short implant. Then after that, even the 8 mm implant was working well. So the implant size are getting smaller and smaller, and and the this conference in the 11th European Council's conference, they have approved a classification by Orat et al. Where they have considered as any implant which is 8 mm or shorter in length, 8 mm or shorter in length, and which has 3.75 or larger diameter are considered as a short implant. This is defined intra or intra body space of 8 mm, right? And then they have given a classification of ultra short implant which is less than 6 mm in length, right? Which are other common terms which have been used in dentistry with the size of the implants. We know that wide implants are the implants which is wider than 5 mm, standard implants which are 3.75 to 5 mm in diameter, the narrow implant from 3 to 3.5 mm, the mini are less than 3 mm in diameter, the long implant which are longer than 13 mm, short implant again I just told it is 8 mm or shorter, and ultra short implants which are 6 or shorter in length. Right? So these are all terms which are now been accepted as a terminology. So these are just for reference, and so whatever talk we are going to do is any implant which is 8 in length or shorter. Right? So before going ahead, we'll just talk about the crown to implant ratio. Because if you see this slide, everybody will start talking about this size of the implant over here and then the crown, because the implant to crown ratio is more. So why this thing comes in our mind, why we are so much focused about implant to crown ratio is because of this. We have learned in our basic dentistry that crown to implant, crown to root ratio should be at least 1:2. When it becomes 1:1 like this, right, where there is a bone loss or some periodontal disease associated with it, then what happens is we consider this as a poor prognosis tooth, right? And if just change the posture. So if this becomes even less than that, so crown to implant ratio is 2:1, then we consider this as a hopeless tooth. And this is so much engraved in our mind that we consider the same rules for the implant. But we have to consider that implants are not teeth, right? So there is so much difference between implant and teeth. So whatever rules which are being adopted for the teeth should not be considered for the implant. What are these? There are three main basic difference between the teeth and the implant. See, if you see this tooth over here, it is in disease. Right? There is already periodontal disease which has caused some bone loss, and now the crown to root ratio is 2:1. Where here, when you have a plant implant placed in a healthy site, you have good healthy region. So this is in disease and this is in good health. So first of all, there is a big difference between disease adaptation and the healthy tissues adaptation. We all know about it, right? So now if we consider the second big difference between the teeth and the short implants. So now normally the root of the teeth are conical in shape. They have a different tooth structure, while implants which are designated as a short implants are normally cylindrical in shape. So they have more surface area, right? And more surface area has better tendency to accept the stresses than the conical or the taper root, right? So we'll come to this point again in the biomechanics also, but this is the second most different. And the third and the most important factor is the periodontal ligaments. If we consider the tooth, we have a periodontal ligament which is between the root and the bone, which absorb all the forces and then distribute the stress, while there is no periodontal ligament in the implant. So why this feature is more important? If you have to remove any or you have to extract any tooth which has been anchored, so you know how difficult it is to remove that tooth. And the same, and if you have to remove the this normal this tooth, then it is much easier for you to remove the tooth. Similarly, if the implant is ankylosed, it is osteo-integrated in the bone, so it has different features than the normal teeth. So what the literature says is the crown to implant ratio, which we consider as a crown to root ratio, should not be applied over here, and that's why we are not so much worried about crown to implant ratio in the short implants, which is the main setback for our thinking. So, is it any questions are there related to this, or we should go ahead with the next topic? Right? Okay, so we should go ahead with the next topic. It's a biomechanics of short implants. Now, if we consider the biomechanics of short implant, normally implants should be same. Any biomechanics of the implant should be same. But there are few differences between short implants biomechanics and the other implants, which are screw type of implants, which we normally do. So, how do they work? Right? So there are mainly three type of forces which all of us know for any implants, which is like compressive, tensile, and shear. The bone is strongest in compressive strength, and it is weakest in shear type of stress. right? So all the forces which are coming on the implant, like if you consider this, right, any forces coming on the implant are normally vertical. No, they are normally shear type of forces, and we have to consider like that only. Right? So this implant is strongest on the towards the vertical forces, and it is biggest to the shear forces. Now, what happens? Why these short implants work well? And that the biomechanics rationale behind using of short implant is the highest stress value is in the crestal portion where very little stress is transferred to the apical region. So when there is a stress given on this point, it is transferred to the implant and the crestal region, because it comes the first contact region where the stress is distributed. It's the crestal part of the implant. So the crestal part of the implant if this is the implant, this is the top part of the implant. It's called crestal part of the implant, which distributes the stress more than the apical part. Right? So what the final element studies analysis suggests that the top 5 mm of the implant has the maximum adaptation of the forces, while the bottom part has very minimum stress distribution of the forces, right? So I have drawn a diagram over here. So imagine this is an implant which you have placed in the bone, and this is an abutment or crown, whatever crown you have here, and this is the arrow which is showing the stress, which is not vertical but uh, the different direction, right? So what will the implant try to do? It will try to rotate from the center part like this near the fulcrum, and it will try to rotate, and in doing so it will distribute the stress from the implant to the surrounding bone. The red area over here is the area which is shows that it absorbs the forces from the implant and it is distributed to the bone surrounding it, right? And if we see this area, blue area. Now, what is the blue area over here? Is the blue area is unused area. Here, it is not distributing the stress which has been transferred from the crown to the implant. Right? So this area is unused here. This red area over here, the crestal portion, top 5 mm, we can say, works as to distributor force. This at the apical last 5 mm is to distribute again to counter effect. It distributes the force from here and here. So this is normal phenomena, or it is physics which we can easily understand. So now what will happen if we increase the length of the implant? Now what if we are not using short implant but we are using the longer implant over here instead of the short implant? And let's see the same way we are applying the force. The force will try to rotate the implant which has been osteointegrated well inside the bone from the center and the fulcrum over here, you can see. And we can see now this red area, the top 5 mm, mostly top 5 mm, and this bottom region, apical part over here, will try and distribute the forces which have been generated on the ground, right? And what we see over here is the blue area. Now, blue area over here is unused area. So, in case we are increasing the implant size from, say, here to here, then we are not increasing the stress distributing area. The stress distributing area almost remains same. Only the blue unused area of the implant is we are increasing. So, the longer implant we use is not going to increase the biomechanics of the implant, but it will definitely give initial encourage for immediate loading. So people use the longer implant as far as possible. Sorry, right? But the for post distribution of the implants, like later on, it is not actually required. So this diagram easily explains us why the short implants work. Right? So what the literature says, increasing the length of the implant does not reduce the intensity of stress along the implant. Right? So right, implant diameter, while the implant diameter is more efficient than the implant length in disability of the stress. So if we increase the length of the implant, it is not going to distribute more stress, but if we increase the diameter, it is giving us more good results. And increasing diameter by 1 mm, if we increase the diameter from 3.5 to 4.5, so suppose if you have an implant 3.5 by 8 and you increase the size from 3.5 mm diameter to 4.5, it is going to have a more better implant than if you increase the length from 3.5 by 8 to 3.5 by 9. Right? The stress is equal to force by area. So if we increase the surface area by increasing the diameter, we are going to reduce the stress. Right? The force we cannot decrease. So what other studies also suggest that if we increase the diameter, it reduces the stress 300% more than if we increase the length of the implant. So the diameter, according to these studies, is more important in stress distribution than the length of the implant. So it is almost the double than the wider implant. It distributes stress double than the slimmer implant. So in your life, if you have a choice of selecting anyone with the slim or the wider, you can select any one of the beautiful girls. That's up to your choice. But if you have to select the implant, always use wider implant, whatever size is possible in that, which will distribute the force much better than the slimmer implant. Right? So we have till now have touched the two main topics like crown to implant ratio and the length and the diameter of the implant. Now we are coming to little bit more deeper about implant design, bone response to different implant designs, right? Because these implants are specifically made for short implants, which has different design, different geometry, which has different bone response, and eventually it works better. And we can use these short implants for rehabilitation of any tooth in the oral cavity, right? So for the implant design, we can say it has two different micro geometry and the macro geometry. The micro geometry like surface area, the macro geometry like thread design, the implants design and everything that. And we can also we'll also talk about implant abutment interface, right? These are the three main part which are going to discuss about the implant design. So micro geometry is the surface structure. Surface structure is like the top part of the implant, right, which we cannot see with our naked eyes. So there are two type of surface structure. We can say the smooth machine surface and the rough texture surface. The smooth machine surface are normally used by the basal implants, where they have a different indications. They have to use an anchorage from the cortical plates. But the most other implants right now available in the market are rough texture surface. The rough surface can be achieved by either a subtractive, when we remove some part from the surface of the implant by like blasting, etching, oxidation, or we can add something, right? Like if you're doing a composite filling, you etch the tooth, like you etch the enamel to get the surface, like it's like etching. The additive process is like you add some like spray, titanium spray, hydroxide, this way, calcium coating, iron. So all this surface texture will increase the roughness of the implant, and in that we increase the bone to implant contact and increase functional surface area, which we have seen the right part of the implant. So it also improves the bettability of the implant surface, which makes it osteointegrate better with the healing site. So that are the two main things which we get with the surface structure. So that we have to see whether which type of implants we are selecting, right? And you have to see the surface structure of the implant. So now we talk about the implant macrogeometry. uh, Implant microgeometry, we are going to talk about thread design. We are not going to talk about the shape of the implant like cylindrical taper, because as I already told you, the most of the specific implant which are short implants are cylindrical in shape. They are not taper in the shape, right? So we are eliminating the taper implant right now. We are just talking about the implant design, right? So there are two type of main design, the threaded and the press fit implant. The threaded implant are the screw type implant, right? And the press fit implants are they are not screw type, they are different type. So I have made small classification over here. Now, what is the threaded type of implant and the press fit type of implant? The threaded type of implant are the normal implants which we use, where you do a small osteotomy, which is normally smaller than the size of the implant. Then with the torque ratchet, you insert in the screw type manner the clockwise direction the implant in the ostomy bed, which you have prepared. Right. So according to manufacturer's advice, they can be 30, 35 Newton torque, which you have to apply on the implant for the insertion of the implant. Right. Now the press fit implant on the same side is a different type of design, where you have to, if you want to put an implant of 5 by 8, you have to do the osteotomy of exit 5 by 8, and then you have to press fit the implant. You have to tap the implant on that osteotomy. So the implant is not going to exert any pressure on the osteotomy side, while the threaded implant has a the threads which will drive the implant inside the osteotomy well, and in doing so it will create some pressure and it will hold the implant in that place. So the primary fixation or whatever we say is must in the threaded implant, and which is not needed in the press fit implant. But whatever you see, this two design has a different total output, and all the short implants which are right now available, specifically short implants, has a press fit type of design, which makes them successful in treating this type of cases. So if we see the threaded implant design, we have different implant threads like V shape, square shape, buttress shape, reverse buttress shape. Right, these are the different designs which the companies come out with. They usually change in every few years, because they will come with a newer type of design and they will say this design is now better. But if you talk about other type of design, right, like best fit design, which are in market since 30, 35 years or more, but they are giving the same design right now. They are more successful in that design. So the practice design or best fit design are the still same. Right, the screw type implant, the threaded geometry will impact both initial osteointegration and subsequently transfer of occlusal stress to the bone during functional implant loading. So so initially the V thread or whatever thread will only get the primary stability, while in this we don't get the primary stability. In press fit implant design, there are two again designs which I have made a small classification. Is horizontal plateau design, right? Like this type of design, or we can say the twins design, and the second is sintered porous surface implants, which are also very famous, and which is also right now not available in India. Endopore, we can say that company has a different type of design. Right? Now, why the threaded implant and the press fit implants are so different? So, what are the different things which makes this press fit implant more successful in the short implants? Right. So, we'll talk this one by one. The first is the surface area. So the surface area of breast fit implant is much higher than the threaded implant, right? So almost we can say it is 30% more than the breast fit implant. If you have the same, say 5 by 8 implant of threaded implant and the same 5 by 8 of the breast fit implant, then it has been shown that the breast fit implants has 30% more surface area for distribution of force than the threaded implant. So this is a small comparison of all the implant companies, right? You can see different sizes of the implant and the surface area. So it is maximum, and this press fit implant, where it is minimum in say this implant, which is has almost half than that of the press fit implant. So here again, I am not advocating any company, but this is a study been shown by the uh, different scientists. So all we know that no stress is force upon given area. So if we increase the surface area, obviously we are going to decrease the stress. And in decreasing the stress, we are going to decrease the stress in the bone, and eventually the bone will become more happier, and the bone stimulation will always happen. Right? So the second important part in different is a differential healing of threaded implant and the press fit implant. So what is this difference between threaded implant and the press fit implant? Implant should osteointegrate the same way, but there is a huge difference between threaded implant and the press fit implant healing. So once you put an implant, a threaded implant, this is the right side, we have a thread implant in the osteotomy wall. We put some pressure on the surrounding bone and while driving the implant, and it will create a primary osteointegration or fixation of the implant. While here, as I told you, we are going to do osteotomy of the same size of implant. We are just press fitting the implant inside the osteotomy. So here you can see the red region over here is the clot or what blood clot formation over here, and here there is implant thread are giving pressure to the surrounding bone. So here there is no on the left side there is no pressure on the surrounding bone, while there is a high pressure 25-30 Newton pressure is given in the surrounding bone for the primary osteotomy. So what happens next is the chambers which were filled by the blood clot over here are now getting the new bone, right? And on the right side, the bone next to the implant is now modification start. It goes changes and osteoclast activity will start and it will remodel the bone around it. So like in orthodontic treatment, when we give the forces from one side, there is osteoclastic activity on the one side of the root, which causes resorption of the bone next to it, and the other side there is traction, which will cause bone deposition. So here there is osteoclastic activity and bone resorption will start in the vicinity of the implant, right? While here the bone formation start immediately inside the chambers of the implant. So this is called contact osteogenesis, and this is called resistance osteogenesis. When here the bone formation makes smoother or easily, and it has a different quality. When this is a different type of bone, because now the osteoblastic activity will start and will try and hold the implant back. And the bone formation over here is called acquisition type of bone, which is different than which is callus type of bone over here. And with this different type of bone quality has a different type of ability to absorb the forces, and that makes the shorter implant again more acceptable than the plateau type of implant, more acceptable than the threaded implant, right? So what happens is in threaded implant, you get high mechanical stability when you put the implant, which is replaced slowly when the gamma phase of the healing takes place. It is replaced slowly by the biological stability. While in the breast fit implant, there is lower initial stability because you are just putting the implant inside the osteotomy wall, which is not going to create pressure on the bone. And slowly, there will be more mechanical stability because the bone will go inside the fins and it will hold the implant properly, right? So this type of different type of healing process take place between threaded implant and the breast fit implants. The cortical bone, which is formed inside the breast fit implant, is much faster in compared to the threaded implant, which is 10 to 15 microns. But if we see the whole scenario, and the threaded implant is 1 to 3, but we see the whole scenario, it takes 3 months for the bone to completely hold the implant in the proper shape. Right? So it is faster, but it takes time. So it is not, we can say that tooth in an hour or tooth in a day is not possible. This type of fin type of design or press fit design, we have to put the implant weight and allow it to osteointegrate before loading, right? Before active loading. Okay? So two-stage protocol is always followed when unsplit short implant are being used. Okay? So this is a different type of healing than the threaded part type of implant. Now we come to a third topic, which is of the bone quality. Now, normally people always tell me that the shorter implants are more successful in mandible than the maxilla because the bone quality is much better in the mandible. So, what the literature also says that D4 type of bone is 10 times weaker than a D1 type of bone, right? So, again, this is quite understandable that if we increase the density of bone, we will have a greater strength with the bone, and less dense bone demonstrated reduction in strength with about 50 to 80%, then and the chances of implant failure are much there in the maxilla than the mandible. But if we see our cases, I will show you the all cases. We have successfully used the short implant in upper jaw, lower jaw, posteriors, anterior, everywhere, and we don't find much difference in the quality of bone, right? So again, this is mainly because of the Wolff's law. It's a German scientist who gave this Wolff's law in 1892, and still we can consider everything related to it. So every change in the function of the bone is followed by certain definite change in its internal architect and its external conformation. So to simplify this, that whatever bone qualities we have in the surrounding of the implant, we can modify it by bone stimulation theory. So I have just put a few points over here. The soft and hard tissue surrounding the implant plays a complementary role, as we all know. So forces delivered to implant thus become a source of strain to stimulate alveolar bone. So if you have a proper type of forces coming on the implant, which is not so high, which is not so low, it is optimal, then the bone stimulation will start. This stimulates the activity of osteoblast. Like we do exercises, then the muscles becomes more stronger and stronger. The bone become more stronger and stronger. Similarly, the osteoblast will activity will start in the alveolar bone around the implant, and the quality of bone becomes better and better over the period, which gives us more positive change in the surrounding area. So you can see over here, in this case, the crown you can see like this is because of the composite crown which we have made, and we have done a progressive loading because we have used a bone graft in this case, and we didn't want it to give an immediate loading. But over a period of time, you can see the quality of bone over here. And there were the crown worked very well, so we didn't replace the crown. We wanted to replace the crown later on with a ceramic crown. But till now, since last 7 8 years, it is working well. And you can see the quality of bone, it is increasing better and better. In all the cases, you can see the bone over here, it is now started creeping. So if there is proper stimulation in the bone, then bone creeping also can be expected, where the bone will start going around the implant and abutment section, and it will give more and more support to the crown, right? That is a whole different talk, but I'm just sharing you right now, right? So again, I'll just innovate that bone quality also does not matter so much if we have planned our implant everything betterly, right? Perfectly. Now we'll come to a prosthetic consideration. I'm going a little bit faster because I think we have less time. Prosthetic consideration, I like to figure out. Just explain one most important thing is implant abutment connection. The connection, it is place where implant are connected to the abutment. It's a junction area. So if you can see this implant and this abutment, this area is called implant abutment connection, where the abutment fits the implant. Right. So this is a screw. This is an abutment which I have drawn. This is the implant. So this area over here is called implant abutment junction or implant abutment connection. So this is a sign up between the forces coming from the crown or bridge or prosthetic value. It will go from there to the abutment, and from abutment it will transfer to the implant. So this junction is very important for us, right? Why it is important? I have made this classification again for just to simplify the things. This is not any published. So if we consider implant abutment connection, we can say there are two type of connection. One is external connection. Nowadays it's less seen, and the internal connection, most company comes with the internal connection, right? So there are three different type of internal connection. One is butt joint or slip fit connection, which is normally mostly 70 to 80% company comes with that. Then comes conical connection or self-releasing taper. Or we can say the conical connection, the 15 20% of the other rest implant company comes. And the third is the Morse taper connection. Now, these Morse taper connection are most successful in a short implant. And so I'm explaining all the other type of joints, implant abutment connection, to why these are more successful. Now in slip fit connection, like there is some space between the abutment and the implant well, right? So abutment can easily go and fit it. Right? I'll just show you model. So imagine this is your implant, right? This is your abutment, so it can easily go here, and then with the screw you can fix the abutment onto the place, right? So this can be passively go inside the abutment. So this type of connection is called slip fit implant. Now in slip fit implant, as it is passive, there is always some space between the implant and abutment, right? Then comes the Morse taper connection. Now most of all the companies which comes with some different type of connection will tell you that we have a Morse taper connection with the implant and abutment. Now what is Morse taper connection? Is a specific connection where you don't require a screw holding for the implant for the abutment over the implant. So it is like glass within a glass, or the connection which does not require any prosthetic screw to hold the abutment in the implant. So then the two perfectly manufactured cones are tightly brought together, and they provide friction lock, or we can say cold well seal, is called Morse taper connection. So this is more favorable connection because there is no micro space between implant and abutment, and the abutment can be fixed without the need of screw over here, right? And the conical or hybrid, right? So any other type of connection which has some geometry with it, like indexing, which is required for anti-rotational thing, or which has some slip fit connection with it, is a conical or hybrid connection, where there is a small part over here, a small geometry which allows the abutment to place on the implant well, and there is a small conical connection also which will allow the top part of it to seal it properly with the implant well. Now this hybrid has goodness of both. We can say the Morse taper connection and the slip fit. But if we see, there is again a micro space present over here, and there is some slip conical connection on the neck of this implant. While the Morse taper connection does not have any micro space between the abutment and the implant. Now, why this is very important for us? Because the average micro gap between the abutment and the implant is 1 to 14 microns. Now, this area becomes a space for or reservoir for bacteria to grow, right? So, bacteria can easily pass through implant abutment connection, and it will stay in harbor in the that space, or we can say the implant abutment connection here. So what are the problems associated with? So problems we can say with the microscope is it causes micro movement between implant and abutment like this, which causes screw loosening, screw fracture, abutment fracture, implant fracture, sometimes titanium abrasion. But right now we are not so much focused, because right now our topic is a little different, but we are uh, uh, interested in biological complications. So what are the biological complications with it? Is the average size of bacteria is 0.5 to 2 microns, right? So again, I just as I told you that it can easily stay between the implant abutment connection, and it causes some toxins which will spread in the vicinity of the implant abutment connection and surrounding soft and hard tissue. Now we have already talked about that the soft and hard tissue surrounding implant complements the bone around the implant. So if there is any infection over here, it will cause the infection in the surrounding region. So what will happen is the microorganism will stay on over here, and the toxins produced over here will cause infection in the surrounding region. And with the cyclic opening and closing, because of the microbit, like when we chew, there is some micro movement between the implant and abutment. This is this type of connection, which will cause a pumping action of the liquid coming in and out from the implant abutment connection, right? So the toxicity will again spread in the surrounding region. So if you get chance to remove the this screw, or for change of prosthetics or any maintenance region, there is smell coming out when you remove the abutment or the implant crown. This is because there is some bacteria between implant and abutment connection which causes the bad smell to that area, right? And if we consider, all the implants, the thread implants, why there is a bone loss around the implant abutment connection once you load the implant, is because of this toxicity which is produced by implant abutment connection, which some literature says that because of that there will be some bone loss which is in vicinity of that toxic zone, which is normally to the first thread. Till the first thread it is been seen, right? So again, I will just enumerate what are the biological complications with this. Is the micro gap which causes micro motion between the implanted abutment. The micro gap will become macro gap, and the bacterial and its toxins will spread in the surrounding hard and soft tissue and will cause infection and inflammation in the surrounding region. Right? So these all complements with each other. Now, why this is more important for us? Now you might have seen this slide, which shows that which is ideal position of the placement of implant. So if you have a soft tissue around the implant, which is say 1 mm, then the equicrestal placement, or which is the placement of the implant in the bone, is equicrestal with the level of crest is not advisable. If it is 1 mm, you ideally have to place at least 2 mm subcrestally, right? So if you have a 2 mm of soft tissue around the implant abutment junction, ideally you should place at least 1 mm subcrestally or 2 mm subcrestally is better. And if you are lucky, you have a 3 mm of soft tissue, you can place the implant equicrestally or subcrestally, right? Now, for short implants, normally we recommend to place the implant subcrestally, at least 1 mm subcrestally. Now, what will happen if your implant abutment connection has some leakage, right? The subcrestal placement of implant also has some other advantage, like it reduce early macro motion of the implant, which ensures a good quality of bone around the osteointegrity side. The crestal bone thickness also gets better, and it increase the cancellous bone to implant contact also, which is important in this type of filling, because we have seen we need a good type of bone around the implant fins, right? So what will happen if you have placed the implant subcrestally, right? Say if you see this scenario, I just shown the slide over here drawing that you have placed the implant subcrestally, say 1 or 1.5 mm, right? After the healing period, you have waited for 3 to 4 months. You have loaded the implant, and everything looks good. After a few months, what will happen? The bone loss will start, and the soft tissue will recede again with that, and there will be some inflammation. And after some time, we will see a bone crater, typically around the first thread of the implant, which is in vicinity of implant abutment connection. This causes bone loss around the implant. So if you have a normal C implant and you have 1 mm or 1.5 mm of bone loss around the crestal, you might be lucky enough to get away with it. The implant might work well. But if you have used short or ultra short implant of 5 mm and 1 mm of bone loss happens, then you have already lost 20% or 25% of your main bone, which is the crestal part, which absorbs the most stress. So it is very important or vital for us to have a connection which will not create micro motion, and no bone loss should happen around the neck of the implant. Once you have placed, we don't want any more bone loss around the implant, right? So you can see this connection over here. The bone has adapted very well surrounding the implant abutment connection, and after even loading, it has not gone below it. Again, I am showing the same slide which I have been shown before, that if there is a good forces coming on it, the bone eventually, if you see the implant abutment connection is over here, and the bone has gone above it. Over here also, implant abutment connection, you can see the good quality of bone creeping around the implant abutment connection, and will become better and better day by day. Excuse me. So the sleep fit or butt joint has maximum space between implant and connection. The hybrid has less space, but once you load it, the conical part of it can create some slippage from it, and it does not work. While the more stepper connection, The company claims that it does not allow any bacteria to grow between implant and abutment, and the space is zero point 0.5 microns, which is not good for the bacteria to stay and remain healthy over that region. So the most taper connection is the only connection which assures the good um, infection-free implant abutment connection. Right? So for the prosthetic part, this is and the other prosthetic part is like how we can decrease the stress on the implant. We can, if you have multiple implants, you can spin the implants, and people also suggest that you can use. But if you have used a specific short implant, even the single sorry, implant can also, as I shown here, does work well. Again, both the unsprinted and sprinted implants have worked well with us, and we are very confident with even sprinting and without sprinting also. And we'll come to the other topics, like you can decrease the forces on the implant by reducing the table on it, or you can decrease the buccolingual dimension of the implant, or you can have less stress on it. You can also use some composite type of material initially for rolling, but that all are secondary things which normally people can manage by themselves. So, so we have now through with the processing. Again, I'm going a little bit faster because I want to show you some cases. Now, are they necessary? Now, why are they necessary? If we see the global scenario, the people said that 65% of the patient have less bone in the maxilla and about 50% in the mandible. But if we see in the Indian scenario, we can expect even more than it, because people come here for implanted very late, or the body profile over here, the bone size is little bit smaller than what we accept in the European or American patients, right? So we have to manage the mental nerve, infra-alveolar nerve, the nasal cavity, the maxillary antrum, the incisive canal. These are all limitations for us, which will not allow us to use the longer implants in the place. and we can place tilted implants, or we can use some other added treatments also, but we'll come to that point. If you have like mental nerve over here, you can use a shorter implant, or you can think about different alternatives. What if there is a huge undercut? This mandible, mandible, which I can tell this like a sinus of the mandible, right? So if you don't put your implant properly, what you are going to do is either you are going to perfect the lingual part of the plate, or if you don't want to perfect, you put the implant in an angle implant. Now, if you put the implant in such an angulation, and the prosthetic is like this, now for single tooth, how much angle you are giving the forces in the implant abutment connection, and this usually follows by screw loosening or screw fracture, abutment fracture. If you are unlucky, the implant also fractures because the forces are not favorable over here. So the tilted single implants like this might be a nightmare if there is some problem. For the maxillary sinus, we all know that this is the main problem where the posterior region we have to encounter in each and every cases. So what are the other solutions? Other solutions, if we consider the grafting solution, so there are many classifications or many ideas, and it works well in some persons, and it does not. It is very technique sensitive. Again, the mandible also, we have so many grafting solution, or osteogenesis or veneer graft, GPR, distraction osteogenesis, are all things which have been tried and tested. But it works well with some person, it does not work well with some person. Again, the morbidity, if you see, uh, so if you have done everything in a proper way, you have done grafting, you have done a membrane, you have done tight closed sutures, and everything works well, then it's okay. But if something goes wrong, then your bone graft is going to thrown off like a sixer. I know the T20 sin has not gone well, but I just wanted to show the stroke. So that bone grafting is eventually gonna vanish, right? So what are other things like if you use the bone graft, it's going to be an added expenditure for you, for the patient. The membranes are very expensive. The type of bone, again, what time it requires for remodeling, how what quality of bone it will be. Eventually, we don't want a white package on the X-ray. We want a good native bone which will absorb the forces of the implants, right? Now, other very right now in trend, we can say India is a we are trend setters and trend followers. So other long tilted implants are right now so much popular. People offer the cortex and with the longer implant to get bicortical fixation. Yeah, that all sounds good, but there are again some complication with it, and again you have to be very precise in doing all these things. People also get surgical guides for it to computer to put the implants properly in the angulation, because if you have to put the implants in the 3D way, we have to go to visually, and the angulation should be sometimes palatally, sometimes it should be buccally. We have to bypass a nerve and everything. So again, the surgical stand, if you go with the surgical stand, it's like guided missiles. You have to believe that your surgical stand is working very well. You're good. You have gone drilling properly. After all this thing, proper drilling and everything, your fixation of the everything goes well, and then you put the implant properly in a proper position, and it goes bang in the right position. And but what the literature says that there are so many errors to this treatment also. So it starts from data processing. What is the feedback of the people who are using a stand? That out of 10, if they have two or three failures, then it is a big problem to them. The error cannot be, easily redoable, or it cannot be modified. So it has an error from data processing, the type of, the impressions you made, the type of production where you get the stents. There are so many things to it. The bursts or cylinders which are being used as a template. So they are very technique sensitive, and it's very small change in this. 0.5 change will give a big difference in the end. So you feel that implant is being placed properly with the guide, but once you take the CBCT and you will it again, and you find out that it is not what you were looking for, or what was implant. So if you are lucky enough, you can get away with this double blow, but most of the time we are very unlucky, and a small touch and go here and there with this surgical stand or whatever longer implant will give you a big problem if you injure any artery or nerve or any vital structures, which can cause problem in your treatment, or which has more problems there. So again, we can go with the sinus lift, with the sinus lift. We can go with the pterygoid implants. Again, we have to consider the failure, how we are going to do the revision of this treatment. The problem with the hemorrhage, the zygomatic implant again, it's now trending, and we can think about shorter implant first, then the zygomatic implant, right? Wherever is possible, try and think about short implants first. So main advantage of the short implants, we all know we can avoid the major surgical treatment like no lateration, no bypass. We can reduce the risk of the for the patient. We can reduce the bone grafting and materials and all these things, and we can very well use the short implants in that places. uh, uh, any questions till now, or I can go ahead with the cases? Right. So maybe uh, which implant is good? Uh, Normally, any implant which has a specific design for the short implants, or should I come to this point later on the question answer? I think it should be better. So, are they reliable? Reliable, we are looking at the long-term success of the implant, right? So, any cases which are going to show is not more than less than 5 years old. So, these are all old cases which I'm going to show. like clinical case. This is of lower right second molar, old lady, 70 years, hypertension and diabetes is very common. We have vertical height less than 10 mm. So this was pre-operative. I'm a clinician, I'm not an academician. So you will not see a good slides with me. You will not see so many literatures, datas. I'm not going to show all these things. I'm just showing to my cases. And because of that, you will see so many loopholes in the prosthetic part. But right now we are not checking all these things. We are just showing how the short implant works more wonderfully, right? So we placed this implant. This was my favorite implant, 5.7 by 6.7. This is abutment checking, and this is the process. I know this process looks horrible, but this was at that time what was available for us. And this is a recent OPG which I have took. You can see the implant is working very well. The opposing tooth also is a ceramic bridge, which she is now has to replace, and all these things she go slowly. And you can see the nerve over here. So it's touch and go. What else you can do for this lady if you want to replace this tooth? Right? Now we are going to even extract this tooth, and we are going to slowly change the process and give her a full more process. Now coming on the upper jaw, and this is a case of immediate extraction, right? So what are the options with you? One option is after the extraction, we can put the bone graft, socket preservation, and come after 4 to 6 months and put the implant. Depending upon the length, we can go for internal sinus lift or lateral sinus lift, whatever. Right? Instead of that, what we have done is we have removed the tooth, checked the residual bone, which was less than 6 mm, and we modified the region and put this implant in this place at the same time of extraction of the tooth. And this was placed in the same sitting. After the healing period, right? Uh, we have loaded the implant with the abutment, and here we have the ceramic tape. And you can see this after 4 or 5 years, the bone stability around the implant. Now you can see you can view very good results are still available with the short implants in the upper maxillary area also. There is no bone loss around the implant, or the bone has adapted very well. Also about the implant abutment junction, and this implant is going to stay for years and years. There is not going to create any problems. Right? This is a recent OPG of that patient. Again, this was wide over here, and next we have placed a short implant. We can use a short implant to avoid distal extension also. Like if you want to do the all on four, you can put two implants on back side, short implants you don't get. It will prevent your distal extension and you don't have to worry about AP square. These are again to avoid the distal extension of the bridge, not only the full mouth cases. This is again a case where we have put the wider implant, 8 mm implant, and easily can restore any tooth. And this is again an interesting case of two ultra short implants. Ultra short implants are which are less than 6 mm in length, male, 55 years, male, uh, quite healthy, strong man, smoker, as OSMF, and the crown length is obviously more in the molar 6-7 region, lower right. Upper jaw he has a ceramic teeth. So this is the while placement of implant 5 by 5 and 5 by 6 implant were placed. In this case, we sprinted the abutment and put the joint crowns. And because the patient was not going to floss and he was tobacco chewer, and we thought that it will be difficult for him to maintain that side. And this is after a few years. Again, you can see the stability of bone around the implant. So even the mandible, where you expect more forces, the ultra short implant also work well. You can see the crown to implant ratio. Again, it's more than 2 or 3 times over here. Right? I think, can I show another case, doctor, or you want me to stop over here?
No, no, it's okay. Doctor, please go ahead. You can show another case.
Yeah, I'll just show maybe one case is again. This is
Sure,
very
sure.
interesting. It's like tight. parking space where you have very little space to park your two cars, right? What you are going to do? So again, this case, we have very little mesodistal space. We have already talked about the vertical bone problem, but this is a little different. So I'd like to share this case also. So we, before going out, we just try to where we should put the implant, and we have marked the place, took the X-ray, and we managed to do a small sinus lift over here and put two implants side by side, right? So we cannot, if you see the anatomy of the maxillary sinus, we cannot put two implants over here. For that, you need to put either lateral sinus lift is required for this type of cases. So here we have very well managed to put two implants. One is very short, ultra short, and this is short implants. This is only possible from going here to here with this short and ultra short implants, right? Without going for any extensive surgeries, no waiting time of 6 months, and we don't want to do bone augmentation. We don't want to scare the patients, and this is the process given after it. Again, you can see so many holes in the processes, but here we are going to discuss only about the short implants. Uh, good. Again, this is a case where the short implants were used. You can see the mesial cantilever over here. It works well. This is in the place where there was a failed implant. We had to remove the implant. There was a void in the bone quality was not good. These implants work because the design works very well. This has different healing time and works well. This is again 5 by 6 implant for the upper first molar, works very well. This is again 5 by 6 implant for the first molar lower. The single, I am not showing you the cases where we have used multiple implants, because in that the stress distribution might go on the longer implants, and you can say that the short implant does not work well. But I'm just showing the cases of only short implants which has been used for individual crowns or individual teeth. Right? This patient, it was a come to us, and we have to remove this implant which was tried as a short implant, and then we have used this implant and place this. Okay, the short implant. Here we have sprinted a bridge used. Short implant again. These are unsprinted. The margins are not properly. 6 by 5.7 was my uh, uh, favorite implant size, which is not available. I used to call it as a fat boy implant. this this case becomes so simple with these short implants, right? We can say second premolar, you just put an implant, and after some months we just come and load it. And this is again the this case already we have seen short implant. This will demonstrate how we use the screwless abutment. So this is a case where implant was already is costing. This is a black healing plug. We remove the black healing plug. This is a crown with the abutment over here. So there is no screw. This is integrated crown to abutment unit, and we just have to tap this abutment on the place because there is no screw. We remove the black healing plug and put this. There is no cement. There is no screw. So the surrounding implant area is more healthier in this type, or more favorable in this type of scenario. Again, I'll just end up with this case maybe. Yeah. A female patient in early implant cases where we want to do more and more cases. This was referred case, and we were not aware about the problem with the restricted mouth opening. So this was initial scenario, and she wanted to get a fixed teeth over here. Again, a tobacco eater in Gujarat is very common. And once we started the procedure, the we cannot see the site properly, the drilling we cannot see, and we were so much frustrated in 2005-6, and and we ended placing this implant, short implant over here, very near to the tooth. But luckily, the implant was too integrated, and we gave this bulky crown to him, and we told the patient this might not work well, and we have to revise this treatment later on. But we'll keep under observation and see how things goes on. But to the surprise, it worked very well. And when we see this patient next, it came with a different crown because their process very changed. But the bone around the implant still works very well. Even you can see the space over here is very less with an adjacent tooth, but this type of implant has a different healing pattern, and you can take away, go away if you have 0.5 or 1 mm distance between the tooth and the implant. And this is also a very interesting case where there was only uh, 2 mm of native bone where we have gone much, different technique has been planned, and we wanted to avoid the direct sinus lift. And with only 2 mm residual bone, we did a sinus, internal sinus lift procedure, and the implant was placed in the bone graft. It's just I'm going faster. So there was no primary stability. I can with the probe, I can move the implant in the area, and it was very dangerous, but we sometimes try to be more heroic, and this was placed in the area. So there was no residual bone in contact with the implant because residual bone was only 2 mm. There was no primary stability for the implant. Implant was placed in grafted non-vital bone. There was no bone putty which was in use, and non-vital bone. And so we cannot expect more, sheer good quality of bone. But when we came back, we have seen this bone around the implant has turned out very well, and we put the abutment and we loaded the implant. And after 5 6 months, we can see this type of bone which has been very well adapted around the implant. So even ultra short implant works very well. I just like to conclude faster. Sorry for the very fast, presentation, but all the data or studies or multi-analysis you can go by your own way, and it shows that it has very good follow-up. You can have good implant placement in the short implants also. And you here, as the question was asked about the type of implant, you have to be very selective. There are so many implants right now. People comes with the only decreasing the length of the implant. So if you only decrease the length of the implant, it's not going to solve the purpose. You have to see the design of the implant, which is good enough to take the forces. And all these factors really matters. So all the short implants are not going to give you the same type of results. So whenever your your implant supplier give you short implant and say that this is short implant, you have to ask whether you can load it for the molars or not. If the company says no, then you should say that this is not going to work very well. So that all other implants are only for decreasing the distal extension. Right, doctor? I'll just end this short presentation. And thank you everybody for listening to me. And if you have any questions, you can always call us or send me an email. Doctor, should I
Yes,
stop?
yeah. Please stop sharing.
Yeah, right. So I think we
All
have.
right. So thank you so much, Dr. Hemang, for the wonderful presentation and the webinar. Now, I would like to share a small presentation. So welcome everyone again to World Implant Expo 2021 by Dentistchannel Online. These are a few of our keynote speakers of the expo, and we started our Implant Expo on 5th of November. Now, moving on, Dentistchannel Online Pvt Ltd is a leading dental media company that aims to spread awareness and knowledge regarding various aspects of dentistry. We conduct regular webinars and courses on different areas of dentistry, and we make sure the topics of the webinar and workshops are kept so that you guys are updated on the latest dental trends. Being a prime member of Dentistchannel Online brings you several opportunities, accredited webinars, and dental courses. Now, being a prime member with Dentistchannel Online brings you with a lots and lots of offers, discounts, and lots of opportunities. So number one, being the most important one, that you will only be given, you will only be awarded by a certificate or any webinar only if you are a prime member with us. So, for instance, the certificate of participation for this Implant Expo contains of 30 CPD points. I repeat, 30 CPD points, which is quite valuable, which is accredited by Dental State Association of Rhineland and Palatinate, Germany. And so if you're not a member with us, you will not be given this certificate. So make sure you go right now and be a member with us and join as a member with Prime Dentist Channel Online. Be a part of our family. And the link for that is given in the chat box. So you can click it. It's 499 Indian rupees or $7 US. And now coming to the next webinars, we're having few next webinars for tomorrow with Dr. Nitin Ahuja, Dr. Syed, Dr. Sridevi, and that is it. So next slide, please. Okay. For latest dental updates, send your full name on this number so that we can send you the details of the webinars, what is coming up next. So everything will be posted to you via WhatsApp. So make sure that you send your full name to us on this number. These are the list of few of our sponsors for Implant Expo: Monoplant, Unicorn Denmark, Biocoin, JTK Bangladesh, Shastri Brothers, Simpledent, Qualia, Novamind, Monoplant. Now for recorded videos, make sure you follow us on Facebook, Instagram, and YouTube. Our Instagram handle is Dentistchannel Online. We are very active there. If you have any query, you can DM us. And we also post our latest updates and latest webinars and workshops on our Instagram page.
So these are a few questions. Okay. So is this presentation mute or there is no music or?
Doctor, there's new music with this.
Okay. Okay.
Okay, so now coming on to Q&A session, let's start with it. So there's one question from Sarian, that which company short implants you should use and prefer as per your experience?
So I'm not promoting any company, as I in beginning I told that I'm not promoting any company, but the Plato design implants, which has pins, are working very well in my hands, and in this last 15-18 years, I have seen that this works very well, and they are specifically short implants. Right. So if we consider the implant to crown ratio, they can go up to 4 times. So the company says it can go up to 4.9 times. But if you consider as an implant, you have a 5 or 6 mm implant, you can go up to 20 mm of crown. And this works very well in my hand. So any design which has a plateau in its macro geometry, you can also think about implant abutment connection, which is very important in this type of implants. And the cold wells in or more stable connection is more needed. So there are mainly 3 implant companies right now, according to my knowledge, which are giving this, and it is easily available. K3, Bicon, and there is one other company, TLC or something. It's a company from Turkey. It's also working very well. The same concept, everything. Yeah.
Okay, perfect. Okay, so I think we are done with the questions here, and thank you so much, Dr. Hemang, for coming on board with us, and thank you so much, participants, for being wonderful participants. And the link for the Prime membership is given on the chat box, so make sure you click it and go on our website so that you'll get more details on it. Well, we'll end the webinar now. Thank you so much. Thank you, everyone.
Thank you.
Have a good night. Thank you.